So this morning we talked about nerve conduction studies and EMGs, and Matt did a wonderful job demonstrating an EMG and nerve conduction study. I actually wanted to ask you, how did you get involved in doing that? It sounds like mostly full-time doing nerve conduction study and EMG. Tell us a little bit about what got you into that.
Yeah, so I'm a physical therapist, and I had a couple different physical therapy jobs with traditional, outpatient clinics. And one of my original mentors was learning EMG and introduced me to it. And I'm kind of a nerd, so I like diagnostics and data tables and kind of solving problems and puzzles. And so I kind of fell in love with the world of EMG diagnostics and sought out an awesome residency program and kind of went all in with it.
What concerns do you think patients have when they come to you for a nerve conduction study and EMG?
Yeah, it has a reputation of being really uncomfortable and painful. And so the main question is, does it hurt? How bad is this going to be? And we try to provide some education up front, even before they get to me, where the scheduler is giving them some online resources that describe the test and kind of describe what it's like. And one of those points being that, the provider will take time to answer other questions and help them feel comfortable with the test before we start. And so we go through that beforehand, but almost every patient that leaves the test leaves saying that wasn't nearly as bad as I thought.
Brandi, you had a EMG and nerve conduction study in front of the group this morning.
I did.
How would you respond to a patient that's concerned about getting the test?
Honestly, it's probably the main question I get when I have a patient that I'm sending for an EMG or nerve conduction study is, how painful is this going to be? And historically, I haven't been able to answer all that honestly because I hadn't had one. But it was, I wouldn't even describe it as painful. It was a little weird. I think the sensation was a little bit weird when you were doing the sensory testing, but certainly not painful. And then the needles were so tiny, I couldn't even tell that they were in. So I would say not really a painful process at all, but definitely a little bit of a weird sensation.
Mm-hmm. So the nerve conduction study felt a little funny.
Yeah.
And the EMG portion is with the needle, and that one
didn't hurt at all.
Almost like an acupuncture needle that didn't seem to bother you too much.
Yep, exactly.
Other concerns that patients have when they have an EMG, anything?
Sometimes there's questions on, if they can still eat and drink that day as normal and take their medications, and the answer is yes to all of those. The one exception is like muscle relaxer medications can change the data a little bit, but other than that, pain medications and whatever else that they may be taking doesn't alter the results of the test, and they can eat and drink and do their normal routine before they come.
How long should they plan to be there when they have their EMG and nerve conduction studies scheduled?
We schedule them for an hour. Most studies are done within 30 to 40 minutes. Ones that turn out to be a little more complex or there's more to test, more that's ordered by the referring provider might take the full hour, but that's in almost all cases the max.
Good.
One question I have is, in what situations do you find EMG and nerve conduction study testing the most helpful in coming to a diagnosis?
Yeah, your classic neurogenic symptoms, so numbness, tingling, pins and needles, and especially when that turns into weakness or muscle atrophy. In that case, there's almost certainly something neurologic going on in the background that EMG can give really specific information on, where that nerve damage is coming from, the severity, the prognosis of it healing.
Maybe we can pull the slide for this video, but one of the best things that you showed was the one on MRI, and how basically there's a bunch of findings that can be seen on an MRI of the lumbar spine, and the findings increase in frequency with age almost to 100%. So just because somebody has an abnormality on their MRI scan doesn't mean that we have an answer to the problem. It also doesn't mean that they necessarily need surgery. And I loved the concept that you brought up, that oftentimes nerve conduction study and EMG can really help us understand the full picture, in addition to history and physical exam and other testing, so that our treatment plans are tailored to the specific problem with a specific diagnosis.
Yeah, imaging is so valuable, especially in ruling out the red flags and the serious underlying things that we need a really detailed picture to find those. With things that happen as the body ages and changes and adapts, and discs herniate, sometimes they heal, and that's often going on in the background. And so, like you said, those imaging findings aren't always the exact culprit of the pain that someone is experiencing. Yeah. And so an EMG can fill in the picture there.
I agree.
Another part of your talk that I really liked was how you kind of talked about the progression of nerve injury, where it generally starts with sensory and then motor and demyelination and axon loss. Do you want to talk about that? I think that's something that would be very interesting to patients.
Yeah, so when a nerve is either compressed, or there's what we call ischemic, changes around the nerve, and so the nerve isn't getting the blood supply that it should to be healthy. The nerve fibers, like any tissue, need that space and that normal blood supply to be healthy and function normally. And so generally we see let me back up a little bit. There's two kind of types of nerve fibers, but two mainly that we're looking at on an EMG. One is the sensory, so kind of the feeling that we have on our skin and being able to feel the world around us, and then the motor fibers, which control the muscles and our movement. And generally the sensory fibers are the smaller ones, and they're affected first in a nerve injury. And that's not 100% of the time, but a general progression would be you'd see those sensory fibers affected, followed by the motor. And so symptom-wise, you would start with experiencing some numbness and tingling, pins and needles, sometimes burning sensations. And then if it advances past that with more time left untreated, it turns into weakness and sometimes muscle atrophy, and it becomes a little bit more severe.
Yeah, thank you.
Yeah, it's helpful, I think, for patients to understand the problem with all the diagnostic testing, and then also the prognosis. Patients come back after surgery frequently where they have improvement of pain, but persistence of numbness, for example, and wonder if something's wrong. So some of that understanding of nerve injury and healing can help us say, well, that's actually maybe what we would expect, or we need to give it more time. Maybe a nerve conduction study and EMG would tell us if these truly are chronic findings, or if there's an acute component. So it's wonderful to have good people like you helping us figure these things out, and I really appreciate you presenting this morning.
Thank you. You're a wonderful group to work with. I tell patients I work with, if I had spine stuff going on, this is where I'd be getting that taken care of.